Okay, let's continue with our discussion of Chapter 4, the Cardiovascular System, Part 2. The next exercise is 423, number 6, an open revision of an AV fistula with the thrombectomy, patient receiving dialysis. In a purple bolded font, I have highlighted those terms that will come into play when choosing this code. When I began looking for my main terms for the index, I started with revision. That did not work. So then I went to fistula. And under fistula repair, I went to an arteriovenous, and that took me to arteriovenous fistula. When I went there, I found arteriovenous fistula revision with thrombectomy. I'm not sure why I have it down twice there. I must have really liked it. So my final code is arteriovenous fistula revision with thrombectomy. And here it is in the code book, 36833. And you see that there was a family of codes. You see my circle with the arrows at the top. That is referring me back to the previous column where the parent code 436833 lives. And I've written in pencil here, revision open AV fistula. That's the part of the parent code that I want to keep. And then I've chosen this code because it says with thrombectomy. And that's what we are coding. Also notice I've highlighted a few things in the notes under the code to help me remember some things. As I've mentioned in previous podcasts, I will continue to mention to you, the thing about CPT that's a challenge to me is all the reading. You really have to read it. There's just no getting around it. What makes a good coder is someone who enjoys that kind of detail. So I hope that you will at least enjoy it enough to get through this class. Okay. Complications of AV fistulas and grafts, a venous anastomotic stenosis. I just bring this to your attention because the balloon angioplasties are performed quite a bit, and they are to restore the patency and the flow of blood through these grafts or these fistulas. And the one that's mentioned, 36902, is a new code. It was another one of those that I had to do some reading. But once you make that mistake once, you don't continue to make that mistake. You go back and read those new codes. And a transluminal balloon angioplasty percutaneous venous comes under 36902. Now when we talk about vascular families, I'm just going to review some things here. I'm not going to spend a lot of time coding a vascular family, just so you understand the complexity of it. An arteriovascular family is a group of arteries that's fed by a primary branch of the aorta or a primary branch of the vessel that's punctured. Most of the time, that's going to be the left common iliac artery, the innominate artery, and the right renal artery. I encourage you to look in your code book at illustrations for these different arteries and veins in the body so you have some idea of where these vessels are. A venous vascular family is a group of veins that flows into a primary branch of the vena cava or a primary branch of the vessel punctured, and that can be the left iliac vein, the right renal vein, or the left brachiocephalic vein. Angiography tells us in our coding guidelines that codes have to be assigned for both the catheter placement, which is considered the surgical component of the code, and the imaging. And that's imaging falls under supervision and interpretation of the images. Selective or non-selective, when you read about this, a non-selective catheter is one in which the catheter is left in the vessel as punctured and not gone any further, or it just goes into the aorta and sits in the aorta. A selective catheter placement, you puncture a vessel to get into the body and then you select where that catheter is going to go within the order of vessels. And that's where that Appendix L comes into play. And this is the type of detail that the interventional radiologist and the cardiovascular coders get paid the big bucks for because they understand this. Each vascular family that is catheterized is coded separately. You assign a code to the highest order within the vascular family, And there is a guideline that tells us not to code for a non-selective catheter placement in addition to a code for selective catheter placement unless there are multiple punctures. It's usually going to be either selective or non-selective catheter placement. More guidelines, the Supervision and Imaging, which is abbreviated as S&I codes, are used to describe the imaging component of the procedure, and those codes are based on the vessels imaged, not the vessels that are catheterized. Two different things. To make it more interesting, some CPT codes include both the catheter placement and the supervision and imaging, and some don't. So you really have to read your code descriptions very carefully and the guidelines around those codes to be sure you don't trip up. A vascular injection procedure can be either intraarterial or intravenous. In the intraarterial injections, there's a selective arterial catheterizations, which is when the catheter is placed where you want it to be, somewhere in the arterial system other than the aorta or the vessel that you punctured. In other words, you are choosing where it goes once you get into the vessels. The non-selective catheterization, you just place it directly into an artery, and it only goes there. It can go into the thoracic or the abdominal aorta, but not anywhere else. When it comes to vascular injection procedures for intravenous injection, I have it there, the language, right out of your textbook. Suffice it to say that the selective is when you are choosing from your puncture where you go in the order of families. A non-selective, you're just going where the needle is punctured. Central venous access procedures are used to administer different medications or treatments. The CPT code assignment is based on the type and the use of the catheter. The only catheters inserted by physicians are coded, not catheters inserted by nursing personnel. Central venous access devices, which are also called CVADs, are used for the administration of meds, like antibiotics or chemo, the administration of fluids or nutritional compounds, like a hyperalimentation for someone who's needing additional help for nutrition, transfusing blood products, or if someone just has to have so many blood draws for diagnostic testing, that's just easier to put in a central line. The categories of venous access procedures are insertion, repair, partial replacement, complete replacement, and removal. Definitions of each one of these procedures is available in the CPT codebook. Coders are instructed not to code removal of a non-tunneled central venous catheter. There's a decision tree in the 2017 CPT textbook, figure 417, that may be helpful in showing you what we're talking about. For insertion of CVADs, you have to decide is it central or peripherally inserted. If it's central, it's either going into the jugular, subclavian, the femoral, or the inferior vena cava. That's often referred to as a central line. A peripheral line, or a PICC line, is placed in usually the basilic or the cephalic vein of the arm, and then it's advanced from there into the larger subclavian vein. It's not going into a central vein like the inferior or the superior vena cava. The word tunneled means the entrance site is at a distance from where the surgeon has entered the vascular system. So tunneled CVADs are usually for long-term use. In the textbook, exercise 422, operative report number 2, is the removal of a venous access port. And I have here the index pathway and the code, 36590. And here it is in the code book. You see there's only a few codes under removal of CVAD. And this one is a tunneled central venous catheter without a port or a pump. The term endovascular surgery is very common now. It means inside the blood vessels. And typically, a procedure begins with an introduction of a catheter that's inserted percutaneously into a large blood vessel. The guidelines around these codes are with the individual family of codes. Just be sure you read those notes above and below your codes. The endovascular revascularization, also called open or percutaneous or transcatheter. I have here a screenshot of those guidelines, my highlights, just to emphasize again the importance of reading the guidelines. Balloon angioplasty and stenting improves arterial perfusion in lower extremities, so it's quite common for that to be used. And as you can see, there are a lot of guidelines that precede the code 37222. Exercise 423, number 4. A patient seen for surgical treatment of an occlusion of the superficial femoral artery left. Percutaneously under guidance, the surgeon inserts a catheter to perform atherectomy, which is a lower extremity revascularization. I highlighted in purple font all the key terms, and the word that I would use for the main term for the index would be the revascularization, which is what an atherectomy is. And you go there, look up revascularization artery femoral, because that's what's occluded is your femoral artery. And there is your code. Be sure and use your modifier, because we do have left and right femoral arteries, because we have left and right lower extremities. And here is the family of codes in the code book. I purposely did not blow it up. I wanted you to be able to see the entire family of codes, my circle around them, my differentiation with the purple highlighter, and the 37225-LT is what correctly describes our diagnosis statement. Here's an angioplasty that is a homework exercise. It's not in your textbook or not in your textbook. A surgeon performs a percutaneous transluminal angioplasty on the left femoral popliteal artery for a patient with peripheral artery disease. Transluminal just means in the vessel. Angioplasty, popliteal artery, intraoperative. You also could have used femoral artery and revascularization as your main terms. And there is our code with our modifier LT. And here it is in the code book. Same class of codes as the previous slide, just a different code. Same family, I should say. Same family of codes, different code within the family. Ligation, division, and stripping of the saphenous vein. As we've mentioned when we're talking about CABGs, the saphenous vein is used for the grafting procedure in a CABG. Ligation and division, the surgeon actually ties off all the tributaries that are coming from the saphenous vein. He ties it off, and then he divides the vessel between where he's tied it, the ligatures. Stripping involves completely removing the saphenous vein from the leg. Because of all the blood flow to the legs, it does not affect circulation in the leg to remove the saphenous vein. That's why it's a great vessel to use for the CABG. It's easy to get to, and it doesn't harm the body when you take it away. In our homework, there's a creation of an AV fistula. I wanted to go through this creation of a fistula. We have not done that. And this particular patient, it says the doctor created an anastomosis. In other words, he directly connected the radial artery and the cephalic vein. So I first looked under creation and AV fistula, and it wasn't obvious what it was, but then there is a main term, anastomosis. When we go there and look at arteriovenous fistula direct, that takes us to the correct code. There is an illustration in your CPT code book as well. And here's the code, 36821. You see I have the entire family of codes circled. The parent code 36818, but the code that describes what we're doing, the direct method, is all the way down to 36821. That's all I have for the cardiovascular section of the code book. It is a bit more challenging. If you have any questions, please post them in discussion board. Provide me with the path that you've tried to use to find your codes, and I will attempt to answer your questions. Thank you so much, and have a nice evening.